speak a bit about the US and the World Health Organization. And I'll speak interestingly, I am CEO of the World Obesity Federation, and which it turns out to also be highly associated with severe complications of COVID. And as such, it's an equity issue, but I've been in Boston for the last 9 months. I was previously in Geneva for 9 years. So I've been sitting on both sides of the Atlantic on this issue at a personal as well as a professional level. So the US has a long-standing relationship with the World Health Organization, which, as you know, was founded in April 1948, coming out of the associated with the UN. And the US itself played a key role. John D. Rockefeller and the Rockefeller Foundation, their own international health programs, helped form some of the core funding and the basis for WHO. The Pan American Health Organization for the Americas was formed at the early part of the last century. So it's a predecessor to WHO, but now also forms the Americas region of WHO. And that itself had its roots in trade in the Americas. So with the yellow fever, particularly around the yellow fever pandemic in the 1880s, which spread up sort of through the coastal areas, through maritime trade, down from Argentina and up through the US, where it killed 20,000 people. So there's a long history of trade and international relations with the US, forming the basis of the US engagement with WHO. As part of this, there were the international sanitary regulations, which were formed around stopping cholera, but meant again to really focus on how countries can engage in trade together, with strong roots in the trade across the Americas, across North and South America. So again, very strong US basis in this, which has its own roots in trade, which I think plays a role in what we're seeing now. The international sanitary regulations formed the basis of the international health regulations, the IHR, which we've heard a lot about in recent months, because the IHR requires countries to report fairly openly and does not penalize them. That's an important piece of this. Does not punish them for reporting openly about potential outbreaks in their regions. The IHR were updated and rewritten after SARS in 2002, 2003, understanding the role that sort of fear of impact on trade and tourism had played in silence around SARS. Important to note, the US was the main author of the revised international health regulations that were approved and adopted at the World Health Assembly in 2005. So again, strong relationships. The US, as we saw with Jean-Marc's slides on the US military, the US is also the largest donor to WHO. So I'll go a little bit into that in the next couple of slides. But again, on the IHR, the focus of IHR is to alert the global community. There's a lot of conversation, a lot of also fake news around when did China tell WHO, what role did Taiwan play, et cetera. The role of IHR, for the most part, countries generally adhere fairly well to IHR, but they also probably ignore it at the same time. We see that in Ebola, where countries did not want to sort of go along with a travel ban, so they just didn't give visas to citizens from the Ebola affected countries in 2014. We're seeing lots of ways that countries adhere to, but also selectively ignore the IHR. So for the most part, China was following protocols around IHR. It should be noted that when Gro Brundtland was Director General of WHO in the early 2000s, she did declare a travel ban for China around SARS, and that was considered a very political move to do that. That was something that certainly created some political challenges for her, but was seen as a moment of real leadership. The WHO is always, as with any multilateral agency, needing to work with, is at the will of its member states. In 2013, 2014, therefore, when Margaret Chan was DG, she was hesitant to declare a sort of an outbreak. And again, remember, an outbreak is a process that's declared well before there's a pandemic is declared. With Ebola, with the Ebola outbreak that was taking place in West Africa at that time, it took quite a long time to declare that. And in the end, 11,000 people died. And that was seen as, in many ways, a failure of WHO not being assertive enough, being too careful, and not adhere, and countries not doing enough around IHR. So fast forward to 2020, Dr. Tedros has been quite open and vocal about COVID, the emerging coronavirus. Went to China, obviously, in January, but also was quite open and public about what was going on. The US has been part of that conversation at the outset. The US was certainly, there's strong US presence in WHO in terms of staff seconded from US Centers for Disease Control and other US agencies, and a number of sort of staff representing the US here in Geneva. And so it was certainly, I was at the executive board. It was a central topic of the EB, and the United States was absolutely a presence there. Now, WHO's overarching goal is attainment of, for all people, of the highest possible level of health. And that's achieved largely through setting normative standards, also through technical assistance, and through playing a global coordinating role. It's important to note here, and I'll just say a couple more things about WHO, is that, it's operating on a budget of about $4 billion a year, which is roughly the equivalent of HUG, the hospital in Geneva. It is well below what the US CDC budget is. It's well below what the US National Institutes of Health budgets are. So it has this very ambitious and lofty goal, and far, far fewer resources than are needed to deliver on that. It has the triple billion targets, which were adopted in 2018 under Dr. Tedros, which are focused around the universal health coverage, protection against health emergencies, and ensuring that 1 billion more people ensure better health and well-being. As it turns out, COVID sits across all of those. Universal health coverage, strong systems, we're seeing the absence of consistently strong systems around the world. We're seeing that in things like absence of PPE. We're seeing it in absence of even monitoring and surveillance. And this isn't just a north-south divide. It's happening, as we're very clearly seeing, in the United States, where health systems are wildly inconsistent. We are seeing, and a reminder, the US spends more on health than any other country in the world, twice as much as Switzerland, which I believe comes in next, with health outcomes that are far below being even in the top 10 in terms of mortality and morbidity. So those are all sort of some of the environmental pieces around the what's going on with the WHO and the US relationship. So the US is the largest single donor to WHO. The next largest donor, the next largest donor to the WHO, though, is Bill Gates. So it's not one of the next countries, it is Bill Gates. The other countries that are sort of the largest donors largely map out against, GDP. Japan is among the largest, UK, et cetera. What's interesting is the vast majority of funding, about more than 80% of funding to the WHO, is now restricted. It's considered voluntary. So assessed contributions are the membership dues to WHO. That 4 billion is 80% voluntary. If you think about that, that gives the WHO very little latitude to be able to respond quickly to new challenges. It's just simply struggling to pay to keep the lights on with the assessed contributions from member states, including WHO. And again, those budgets sit across many different functional areas. It's very difficult to create a cohesive response. In terms of the WHO budget and the US role in it, the shift has been largely from trade to aid, is how I would put it, and development funding has played an enormous role in how funding is delivered, and a lot of those voluntary contributions are on the development and aid side. Very good, helping in lots of critical health issues, maternal and child health, HIV/AIDS, et cetera, but not allowing for new health challenges that emerge, and not allowing for cross-cutting health challenges. As it turns out, two of the biggest health challenges in the world that we're witnessing right now, outbreaks, and also the rise of non-communicable diseases, chronic diseases, are diseases that affect everyone everywhere. This everyone everywhere model is something that WHO funding, its relationship with US and US funding have not caught up with. So there's distorted and misaligned funding and structures that make it very difficult for cohesive responses, and again, contribute to some of the challenges. I think it boils down to in the US and WHO, though, there has been a long-standing relationship between the two. But as the US is, you know, as populism is growing, and as the US is currently in a situation of not trusting multilateral institutions, of a fairly anti-UN stance, WHO is paying the price. For the most part, what's going on is in many ways a distraction as well. Can the US relationship evolve with WHO in what I would call a multipolar world, which is what we seem to be? We're away from sort of the Cold War instruments that created things like the kind of funding models for WHO, but also US's own stance in terms of you're either with us or you're against us. That doesn't work in a health challenge like a pandemic, where everyone is at risk, everyone is affected. That type of populism also tends to be sort of not fairly disposed towards multilateral institutions. I'm conscious that we're short on time and that we're behind time, so I'm going to cut short my presentation, but I'm happy to bring additional perspectives, both as through my professional work, but also sitting here in the United States about some of the challenges that we're seeing right now. Thank you very much. I look forward to hearing from my other speakers.